Good morning. Why don't we go ahead and get started? So this morning, we have actually two University of Colorado trainees who are the future of academic surgery. And the first speaker is Dr. Kristine Corkum, who is an assistant professor in the Pediatric Surgery Division, obviously based at Children's Hospital. She did her undergraduate training at Holy Cross, then went to medical school at Tufts, did her general surgery residency at Northwestern, and then came here to the University of Colorado and Children's Hospital to do the Pediatric Surgical Fellowship. She joined our faculty 2 years ago. I was reading through her CV, and I think you won just about every award possible during your training as a college student, medical school, and a surgical trainee. She always ascended to whatever the leadership positions were and took them on and did a great job. She's helping to build the surgical oncology service at Children's Hospital. She's funded by Cancer League of Colorado, which is a big deal. She has already 30 peer-reviewed publications, and I think I had about that many when I was applying for associate professor in my faculty position. So she's off to a great academic surgical start. And this morning, we will hear about pediatric oncofertility. And just to, I think all of us have friends who were treated for cancer either in their childhood years or adolescent years and know of their issues with having families. And I think what you're doing is very important and really will change the lives of many of our pediatric patients as they go into adulthood and want families. So thank you.
There it is. Excellent. Perfect. Thank you, Dr. Schulich, for that beautiful introduction. And thank you for the opportunity to present this morning. I have no disclosures. A few things that I want to talk about during this lecture is, first of all, to define oncofertility, but also think about it in a way to highlight why it is important for our pediatric and adolescent patients. And I'd like to review current pediatric oncofertility practices. And then if we have time, highlight some of the ongoing and future oncofertility research that we're doing at Children's. Who here in this room has heard the term oncofertility before? Great. Well, oncofertility was a term that was coined by one of my mentors at Northwestern, Teresa Woodruff, back in 2006. And she developed this field of medicine that was concerned with minimizing the negative effects of cancer treatment on the reproductive system and fertility, while also assisting individuals with reproductive impairments resulting from their cancer therapy. And when we think about why is oncofertility important for our pediatric patients, we have to think about it in terms of improved survivorship that we are seeing in pediatric cancer care. The 5-year childhood cancer survivor rates have increased from 56% in 1975. Up now in 2024, patients who are diagnosed with a pediatric cancer can experience upwards of 85% survival. And this is due to advancements in medical and surgical therapy. I really like this figure here because it shows the projected growth in the long-term childhood cancer survivor population in the United States, starting in 1960 and projecting through 2040. And this is the number of 5-year childhood or adolescent cancer survivors by diagnosis. And you can see the great upward trends that we are experiencing. So now this has shifted focus from survivorship and improving outcomes, but looking at more of quality of life for patients and their families. We know that 2/3 of our childhood cancer survivors will experience a late effect of their treatment. And there have been a lot of energy, resources, and time put in trying to minimize cardiovascular toxicities, respiratory issues, nephrotoxicity, cognitive developmental delays and hearing loss, and also addressing secondary malignancies, But one area that has not received as much attention or resources is addressing the potential of infertility and premature gonadal failure for our patients. We know that long-term childhood cancer survivors highlight future fertility potential as a significant quality of life factor, and that we also should appreciate the effects of reproductive hormones, such as estrogen, on the long-term cardiovascular health of some of our female patients. So what are we doing to try to work on preserving future fertility and reproductive hormone function for our pediatric patients? Here's a pediatric oncofertility care cascade, starting with diagnosis down to gonadal tissue use. I will tell you each one of these sections of the oncofertility care is deserving of its own lecture. So forgive me as I work through these things quickly this morning, just to highlight what we're doing. So oncofertility care starts with the diagnosis. This could be a new cancer diagnosis, a benign hematologic disease that may require a stem cell transplant, or even medical diagnoses that will see gonadotrophic therapies. Once we have a diagnosis, we move on to risk assessment. And risk assessment is something that we take into consideration, and we look at the chemotherapeutic agents a patient may be exposed to, whether or not they're going to receive radiation as part of their treatment plan. And lastly, whether or not surgery possibly could affect their future fertility potential. In 2020, there was a publication from the Pediatric Initiative Network of the Oncofertility Consortium that defined risk categories for our male and female patients. These risk categories fall into three groups: minimally increased risk, significantly increased risk, and high level of increased risk. For male patients, things that we're looking for in terms of affecting future fertility potential are exposure to alkylating agents such as cyclophosphamide and ifosfamide, whether or not they undergo myeloablative therapies, heavy metal exposure such as cisplatin and carboplatin, and then radiation exposure to the testicle or hypothalamus. For the purposes of this talk, I'd like to focus on the males that fall into the high level of increased risk. These are the patients that we have fertility preservation options to offer. So those that are a high level of increased risk will have a cyclophosphamide equivalent dose of greater than 4 grams per meter squared, will undergo stem cell transplant and exposure to myeloablative therapy, and then radiation exposure to the testicle over 4 gray. For female patients, the same risk stratification table exists, but you'll see that there are subsegments that are divided into prepubertal and pubertal patients. The reason for that is that the prepubertal ovary is resistant to chemotherapy and radiation more so than the pubertal ovary. Again, if we look at the category of high level of increased risk, because those are the patients that I take care of as a pediatric surgeon, you can see that alkylating exposures greater than 12 grams per meter squared from a cyclophosphamide equivalent dose and 8 grams per meter squared are for prepubertal and postpubertal exposure. Again, exposure to myeloablative therapies, and then radiation to the ovary at 15 gray for prepubertal patients and greater than 10 gray for our postpubertal patients. You can see heavy metal exposure, cisplatin and carboplatin, does not have as a significant effect for our female patients. So these are all things that we are keeping in mind when we risk stratify our patients and talk to our families about the future risk. So once we have a risk assessment, we move on to oncofertility counseling. The American Society of Reproductive Medicine, the American Society of Clinical Oncology, and the American Academy of Pediatrics all have position statements that say any patient who receives a new cancer diagnosis should receive oncofertility counseling to understand their risk and options available to them. We are very fortunate here to have a robust fertility preservation and reproductive late effect program that encompasses providers from oncology, surgery, gynecology, urology, research, genetics, ethics, and our survivorship programs. And so we are fortunate to have these resources to help risk stratify, but also counsel patients and families appropriately. When we talk about oncofertility counseling, each patient gets an individualized, personalized risk assessment. And this is based on their diagnosis, but also their planned treatment. And for the majority of our pediatric patients, they're treated either on a children's oncology group or COG protocol, or according to a previous protocol. So we use those roadmaps to try to figure out their cumulative chemotherapy exposure, as well as if radiation factors into their treatment plan. We have discussions of their anticipated treatment effects on fertility and hormone function, and importantly, we provide them education regarding oncofertility initiatives that are available to that patient and family. What factors in most, though, in terms of what is available is their pubertal status. Is the patient prepubertal or are they postpubertal? For our prepubertal patients, we have two options. For males, testicular tissue cryopreservation is the only option available to them. And as for our prepubertal females, ovarian tissue cryopreservation is the only option. And this is because they are sexually immature to undergo some of the options that are available for our postpubertal patients. As you can see, if you're postpubertal, you have more options available to you, but not all of them are appropriate for our pediatric age patients, such as embryo cryopreservation. And sometimes oocyte or egg harvest retrieval is not appropriate in terms of timing for our pediatric patients and also is an invasive procedure. For our postpubertal males, we encourage all males who receive a new cancer diagnosis to try to sperm bank prior to initiation of therapy. And then if there are issues with sperm banking, we can sometimes offer testicular sperm extraction for those postpubertal males. For the purpose of this talk, I really want to highlight testicular and ovarian tissue cryopreservation because as a pediatric surgeon, that is what I can offer patients and families. For our fertility preservation procedures, we say that our patients need to be well enough to undergo a same-day procedure. The reason for that is that we don't want to do something that will delay their onset of medical therapy, which is truly what's going to save them and carry them on through treatment. We do make every attempt to coordinate these fertility preservation procedures with other procedures that are necessary for the patient to try to combine them under one general anesthesia and also reduce costs for patients and families. Things that we'll try to coordinate with are central line placement, bone marrow biopsy or aspiration, lumbar punctures, and sometimes we'll even do these fertility preservation procedures at the time of tumor resection. Prior to proceeding with one of these operations, there's no specific gonadal preoperative imaging that's required for either testicular or ovarian tissue cryopreservation, but we do like to get some baseline laboratory studies, specifically looking at baseline hormone labs such as follicle stimulating hormone, luteinizing hormone, anti-Müllerian hormone, estradiol, testosterone. These are helpful not only preoperatively, but to follow them long-term in terms of through their survivorship and post-treatment. And lastly, we do obtain infectious disease panel, and this is to be compliant with long-term tissue storage guidelines. And we'll talk a little bit about that as we go through the oncofertility care cascade. Testicular tissue cryopreservation, this is the procedure we'll perform in prepubertal males. And it's a surgical procedure to remove immature testicular tissue because these patients are unable to sperm bank. We perform a testicular wedge biopsy via an open scrotal incision, and our IRB at Children's allows us to take 25% of the testicle to send off for fertility preservation. There are other institutions that allow different percentages. It's very institution specific as what you're able to procure. It's still considered an experimental fertility preservation technique as there have been no human live births from the use of prepubertal tissue, but we'll talk about some of the research initiatives that are happening to try to be able to use this for patients and families. Just moving through some of the operative steps, you can see us exposing the testicle here. I usually place a couple stay sutures to help with performing the wedge biopsy. Again, we remove 25% of the testicle, get hemostasis, close it up back up, and then return it to the scrotum. Some of my previous work at Lurie at their fertility hormone restoration and preservation program, we found that testicular tissue cryopreservation wedge procedures are safe and did not delay any sort of ongoing medical therapy. Ovarian tissue cryopreservation is the surgical procedure that we offer to female patients to remove ovarian cortical tissue. We most often perform these laparoscopically to perform a laparoscopic oophorectomy. And this can be performed in both prepubertal and postpubertal females, like we showed in the graphic previously. It does not require any hormonal stimulation prior to the procedure, which is why some of our postpubertal females decide to pursue ovarian tissue cryopreservation. Because oftentimes to do egg retrieval, you have to go through at least a 2-week cycle of hormone stimulation. And then the egg retrieval itself is often pretty invasive and requires general anesthesia for a lot of our adolescent patients. Again, some of my previous work showed that this was a safe procedure with minimal perioperative risks. This is an abdomen of a 2-year-old female who is at high risk for treatment-related fertility loss. This here is a prepubertal ovary. It's about 1 centimeter in length and less than 1 centimeter in width. This is a beautiful picture of the fallopian tube, the mesovarium. And what we do is we start the dissection from medial to lateral, and we use an advanced energy device to take the mesovarium, the blood supply. Once the gonadal tissue has been removed, its next step is to go for tissue processing. For both testicular and ovarian tissue cryopreservation, the gonadal tissue undergoes a slow freeze cryopreservation process. For tissue that's harvested through the wedge biopsy, it can either be processed as intact testicular fragments or as a cell suspension for future use. For ovarian tissue cryopreservation, a lot of work happens to process into cortical strips. This is more important for a postpubertal ovary that includes a medulla in the middle, and the cortex is the outside of the ovary that contains all of the follicles. For a prepubertal ovary, the ovary gets processed as a whole. And you can see here that once it's in the cryopreservation media, it goes to the lab, the ovary gets bivalved. If it's a postpubertal ovary, the medulla gets removed and just the cortex is processed further. It's cleaned up here in the cryopreservation media. It's processed into cortical strips, and then these cortical strips get placed in cryovials, which will then get processed for slow freeze cryopreservation and then stored for long-term storage prior to use. So once the tissue has been processed, the tissue will get sent for long-term storage. And I would say the majority of institutions that perform fertility preservation procedures for pediatric age patients, they send their tissue to FDA-approved and American Association of Tissue Banks accredited long-term storage facilities. And this is where patients and families will keep the tissue until they're ready to recall it for use for either fertility restoration or hormone restoration. One of the questions I get asked quite frequently is what happens if a patient dies prior to their tissue being used? There are position statements from multiple societies saying that you are not able to use the tissue posthumously. It cannot be used for posthumous reproduction. And when we counsel patients and families, we talk about what would happen to the tissue if the patient were to die prior to use, and they get to choose whether they discard the tissue or whether they donate it to research. And lastly, why are we doing this? What can we do with the gonadal tissue in the future? As I mentioned, testicular tissue cryopreservation is still an experimental fertility preservation method, as there have been no human live births from the use of prepubertal testicular tissue. But for many of our patients and families, there is going to be at least a decade or two before they're going to be using this tissue, which allows for significant scientific advancement. There have been significant ongoing efforts to improve outcomes for the use of it with autologous testicular tissue grafting, spermatogonial stem cell transplantation, and then in vitro spermatogenesis. For each of these efforts, there have been successful live births in murine models and non-human primates, but there's continuing efforts to do this in a human. For ovarian tissue cryopreservation, there are multiple options to use the cortical tissue that's been cryopreserved. You can use it in an orthotopic position for transplantation, a heterotopic position, or you can also use the tissue to perform in vitro maturation of primordial follicles. For women who have no risk of transferring malignant cells, it is recommended that they use it in an orthotopic position. And what does that mean? Most of these procedures are performed by doing a laparoscopic unilateral oophorectomy, but the contralateral ovary remains. And you can use that as a vector to then transplant the cortical tissue under the remaining cortex. Or you could place the thawed cortical tissue in a peritoneal bursa that's near the fallopian tube. For patients who may have a risk of transferring malignant cells that live in the stroma of the ovary, some of these patients are those with hematologic malignancies, it's recommended that you pursue maybe possible in vitro maturation of the oocytes. And there have been efforts to also work on developing a 3D printed scaffold or alginate or fibrin scaffold to support these primordial follicles. So in vitro maturation takes those primordial and primary follicles and moves them through the maturation cascade to a pre-ovulatory follicle for in vitro fertilization. What are the outcomes for ovarian tissue transplantation? 60 to 90% of thawed ovarian cortical tissue that's reimplanted will have successful restoration of hormone function, which is not insignificant, as we talked about the significant cardiovascular benefits for our female patients. Currently, there's about a 30% success rate of transplantation, resulting in live birth from the use of ovarian cortical tissue. Of those that result in a live birth, 50% have been reported to be spontaneous pregnancies, and the other 50% have required assisted reproductive technology to achieve pregnancy. As of today, there have been over 220 live births from transplanted cortical tissue, with the majority happening from transplanted post-pubertal tissue when it was harvested. But there have been reports of 2 live births from pre-pubertal tissue that was re-implanted. And then they also have used cortical tissue to help move patients through the pubertal transition without the use of exogenous hormones. And then the other thing that we look at is multiple strips of cortex can be cryopreserved. And then so if a strip in the cortex, the hormone function starts to peter out, you're able to retransplant. And the average graft length can be from months to upwards of 5 years. And there have been reports of one single cortical tissue graft being implanted and resulting in multiple live births. So all of these outcomes, we are very transparent with our patients and families when we're doing our counseling to report what are the current outcomes for the methods that we're suggesting or presenting to them that they can pursue for fertility preservation. So as you can see, pediatric oncofertility is a developing multidisciplinary field that I can assure you that there are ongoing efforts to advance our risk assessment, our counseling approaches, how we approach surgical techniques, how the gonadal tissue is processed, and then how it's stored long-term. And as I mentioned, there are significant efforts looking at reimplantation strategies to try to increase the efficacy of both testicular and ovarian tissue cryopreservation. Some of my previous contributions to the field of oncofertility included efforts to standardize the surgical approach for ovarian and testicular tissue cryopreservation. Also was part of the early development of tissue handling and processing protocols, and then also reporting the safety and efficacy of these surgical fertility preservation procedures, especially for our prepubertal patients. What I'd like to do now, since we have some time, is just to highlight some of the few current research initiatives that we have ongoing at Children's to try to improve the delivery of pediatric oncofertility care. So one of the first things I wanted to focus on was how can we streamline risk assessment? Like I said, we are very fortunate here to have a strong multidisciplinary team of providers that are well-knowledged in how to risk stratify for our patients and families. But there are some institutions that aren't so lucky to have such a strong team. So what they rely on is provider initiative to figure out a patient may be at risk for future infertility or premature gonadal failure. And then they have to go through the COG protocols and do manual summation of chemotherapy and doses. And if anyone's ever seen a COG roadmap, that is quite challenging to try to actually figure out what the cumulative alkylating agents may be, or heavy metals if it's the case of a male patient. And then once you have those totals, then you can apply them to a cyclophosphamide equivalent dose calculator, that these are usually available online, and then take those totals and then cross-reference it with the risk tables that I presented earlier. As you can see, it's multi-step and there's multiple layers where there could be error, and then it could lead to potential missed opportunity for fertility counseling or miscategorization of their risk. So what I've done is streamlined this and developed a pediatric oncofertility risk calculator. I started with our patients who have extracranial solid tumors, since they have multimodal chemo, radiation, and surgical therapy, and can often be quite challenging to risk stratify. So I created an algorithm to assign treatment-related infertility risk based on these variables: solid tumor diagnosis, COG study enrollment arm, with a patient's sex, pubertal status, and whether or not they receive radiation exposure as part of their treatment. And then the algorithm run, and then it would pop out a risk identification group, including high level, significantly increased risk, or minimally increased risk. And I've been fortunate enough to have this project funded by the Cancer League of Colorado. We're looking at validating this tool and implementing it. As of right now, we have a significantly high sensitivity and specificity of the algorithm to risk stratify at the time of diagnosis. And we have ongoing prospective validation of this tool happening at Children's. And lastly, we have plans for expanding this to all oncology and high-risk medical diagnoses to make this available to providers who may not have the same capabilities to risk stratify as we do here. And I'm hopeful that we can do a multi-institutional implementation study in the future. One of the other things that I'm focused on is looking at oncofertility practices in North America, and going back to those guidelines that I highlighted earlier that says we should broadly counsel everyone who receives a new cancer diagnosis. But I can tell you we do not know how we're doing to meet those benchmarks in North America, as there's no data available. We proposed a study to the Pediatric Surgical Oncology Research Collaborative, which is a collaborative of 50 institutions across Canada and the United States that take care of pediatric oncology patients. And through a competitive process, our proposal was chosen. And our proposal is going to look at current oncofertility practices for children diagnosed with extracranial solid tumors who are at high risk for treatment-related fertility loss. More specifically, patients with Ewing sarcoma, rhabdomyosarcoma, and high-risk neuroblastoma. And the study is going to look at current oncofertility resources at PSORC institutions, and then more importantly, look at how we are doing in terms of counseling and oncofertility practices and pediatric fertility preservation procedures. And I can tell you that this cohort of 50 institutions is quite heterogeneous. Some are large academic institutions that have oncofertility programs. Some are institutions that do not have established oncofertility programs. So I think we're going to glean a lot of information from this study. We're currently in site enrollment, and I'm looking forward to be able to present the results of this in the spring. And then lastly, as one of my kind of passions, I have some previous bioethics training. And again, going back to those guidelines, there are sometimes that these conversations can be quite challenging, and there are challenging oncofertility counseling scenarios that I'd like to study a little bit further to be able to provide better pediatric oncofertility care. These guidelines have no frameworks built within them on how we incorporate patient-specific factors into counseling. I showed you the 5-year survival rates for patients that's greater than 85% overall 5-year survival. But what I'm interested in those are patients who may not survive their disease. And how do we factor prognosis and clinical condition into our oncofertility counseling practices? I think it's best to do this through qualitative research, and this is my mission through some career development awards, to look at provider and patient and family perspectives and lived experiences through qualitative methodologies, through semi-structured interviews, to then to be able to develop a shared decision-making framework for these difficult oncofertility consultations, with the eventual goal of implementing these frameworks and trying to make more unified pediatric oncofertility care. So in summary, pediatric oncofertility is an essential component of comprehensive oncology care. There are fertility preservation options that exist for our pediatric age patients. And lastly, we're making ongoing efforts to enhance the delivery of pediatric oncofertility care. Thank you, and I'm happy to take any questions.
Thank you, Doc. I think we have time for a question or a comment, anything? Please, Peter.
That was great. I have just a practical question. As someone who personally dealt with infertility and spent well into, well over $100,000 to get across the finish line, how do you deal with the cost of the preservation, and is it based on, I'm well removed from pediatric surgery and residency, but my recollection is that we took care of people with a variety of socioeconomic challenges. So how do you manage that?
Right, that's a question that we get frequently, so thank you for bringing that up. For ovarian tissue cryopreservation, over the past 5 years, it's moved into clinical care. And so female patients who are at risk for treatment-related fertility loss can have ovarian tissue cryopreservation covered by insurance. And Dr. Leslie Appiah, who's the head of the fertility program here, has made tremendous efforts to try to move tissue processing and storage here on the CU campus to try to minimize some of the associated costs for tissue transfer, processing, and long-term storage. For long-term storage for patients, there are ways to reduce the cost through financial aid, and it comes out to be about $75 to $300 a year, but according to need. The other thing we do talk about with patients and families is that I cannot currently project the costs that will be for them to use the tissue in the future. I don't know what those associated costs are, but we're working on doing an economic cost analysis to understand the upfront costs with projected analysis for the future. We struggle with testicular tissue cryopreservation for our male patients as it's still considered experimental. And there are some still out-of-pocket costs that we have patients and families have to endure. But we're multiple ways that we're trying to reduce that to make it more equitable and accessible for patients and families. Thank you for that question.
What I like about that is you're leading the curve on this, right? There's so many unknowns, including cost, outcomes, and you're also preparing for what's capable 20 years from now, right? So well done, and thank you so much. Thank you.
Thank you.
Okay, our next speaker is Dr. Dan VanDerPloeg. He will be giving a talk on growing a thoracic surgery clinical program, specifically at Denver Health. He is an assistant professor of GITES based at Denver Health and is division chief of thoracic surgery and associate director of the trauma and acute care surgery service. He did his undergraduate training at Eastern Kentucky University, medical school at the University of Kentucky, general surgery, as we all know here, at the University of Colorado, and his critical care fellowship in the program with CU and Denver Health. He has published on repair of rib fractures with thoracic surgical approaches. He spent multiple months rotating with me as a junior, middle level, and chief resident, and did an excellent job. He's really become a leader in the surgical programs at Denver Health. And Dan, we look forward to your talk this morning. Thank you.
Thank you for the opportunity to come and speak with you, and thank you, Dr. Schulich, for that great introduction. So, as mentioned, I want to talk about growing a thoracic surgery program, a clinical program at a safety net hospital. I have no disclosures. So the objectives for this conversation is, first, I want to review and establish the clinical need for such a thoracic surgery program. I want to review and discuss the clinical expansion initiatives that I've done and grown over the last 2 years, and then review and discuss the educational initiatives as well. So first, onto the clinical need. So a little bit about Denver Health for those who may or may not know. Denver Health is a safety net hospital in Denver that provides great care for all patients, regardless of insurance or their ability to pay for that care. It's a renowned trauma center, known and well published on that subject. And as I mentioned, it's dedicated to providing high quality, cost-effective, and sustainable healthcare for all the patients. It is also a unique academic healthcare practice. So the general and trauma surgeons there, we all have a very wide breadth of clinical practice and provide all of the surgical subspecialty care for our patients, with a focus on outcomes and the quality of care that we provide, with following that and making sure that we meet the metrics and our outcomes are similar to national averages. And what this encourages individual surgeons to do is to develop a clinical niche. And what that clinical niche is something within their clinical practice that they're interested in, and that they can become the subject matter expert. And what that translates to is a busy elective practice that helps improve outcomes for the urgent and emergent care that we also all participate in, as well as group collaboration. So an example there is, with my clinical niche in thoracic surgery, I'm able to mentor and assist my partners in other cases that come up that they may or may not feel as comfortable with. So my elective practice makes me more familiar and comfortable with those types of surgeries. And then also I want to mention the collaboration and the partnership with the University of Colorado group here. What that allows us to have is, one, an open conversation and an expertise, but also an avenue for clinical and translational research, but also clinical referrals for those more complex cases, whether it be thoracic surgery or surgical oncology or whatnot. So next, I want to look at the clinical need of the Denver Health thoracic surgery demand. And the way that this data was used was to justify a position for thoracic surgery. And what this actually did was looked at really the internal opportunities. So what referrals were we missing out on from within the Denver Health system? And what we looked at were the impaneled patients and then the expected anticipated growth of those impaneled patients of Denver Health. So those are Denver Health primary care established patients. And then we looked at all the DRG codes for thoracic surgery cases and actually used market rates within the Denver Health market. And what you can see here is a steady increase in the projected volume of thoracic surgery cases over 4 years. And that is anticipated to continue over a 5-year and even a 10-year change. And a lot of that is based on just population growth and the same actual use rates for these DRG codes. And then going into elective thoracic surgery volumes, those have also increased over time at Denver Health. This is looking at just our volumes. Here for these two charts, you can see green is from before I started at Denver Health, and then blue is for after. And I pulled just numbers for the last 5 years and 2024 year to date for two kind of common VATS or thoracoscopic cases that we've done. So mediastinal mass resections and VATS lobectomies. And what you see is a general trend of increasing volume over time. And so all this data was used to justify an expansion for 1.0 FTE surgeon. And the way that my position was created was a 0.7 trauma, general surgery, critical care position with a 0.3 FTE for thoracic. And what that divides up into is service weeks and call for the trauma and EGS component of the job, as well as some general surgery clinic. And then thoracic, that volume is, again, thoracic surgery clinic, but also 8 10-hour elective thoracic surgery OR blocks, as well as weekday inpatient call and multidisciplinary clinic. And so what this also correlates to is an increase in OR cases. And so predicted that the 0.7 FTE for trauma and EGS would we get about a little less than 115 cases, and the thoracic component would be a little less than 48, which altogether goes to an increase of 160 cases a year to justify creating this position. So moving on to some of the clinical initiatives that I've driven and gotten through the finish line as I've been there at Denver Health. One of the first things I worked on was a clinical referral process improvement. And so stepwise, what I did here was I developed clinical referral guidelines, and I published this as a policy within the Denver Health system for all other specialties to be able to reference. And then creating a separate referral order for thoracic surgery. So what this also entailed was pulling thoracic surgery out from underneath of the umbrella of just general surgery so that both the clinical and OR cases, those volumes could be tracked and metrics could be followed. And then I linked this referral guideline and policy that I published to the referral order so it can be viewed in real time when placing an ambulatory referral to thoracic surgery. And then I also, for networking and kind of messaging out, I attended an internal medicine grand rounds for an introduction and a demonstration of what we offer at Denver Health. And so what I show here is just a sampling of that guideline and that policy. And so it shows, the referral criteria, so the age to be seen in the adult clinic over the pediatric surgery clinic, and then just some general guidelines in terms of health with an A1C less than 10. And then you see here for pulmonary nodules, we have a size cutoff, and that's to be referred to thoracic surgery versus pulmonology, obviously lung cancer. And then on the far right, you see the lab tests or diagnostic tests that we want ordered and completed prior to a referral. Most of these are going to be just 3-dimensional imaging. And then next thing I worked on, I actually did this with our emergency general surgery chief. So we developed urgent thoracic surgery practice guidelines. And what we started with here was creating a formal policy of when to consult the two services. So when something fell under thoracic surgery versus when something fell under emergency general surgery, and when to consult each of those services. In addition, we standardized the inpatient management. So we collaborated as an entire group to agree on the management of those urgent thoracic surgery processes that we determined to fall under the consult to emergency general surgery service. And then I also developed some resources and support for both my partners at Denver Health, but also residents regarding the management, both intraoperative, post-op, and outpatient. And so what we decided on as a group was that 3 things would fall under the emergency general surgery consult service. those being spontaneous pneumothoraces, pleural disease, things like empyemas, effusions, retained hemothoraces, and then inpatient lung or pleural biopsies. And then the things that fell under more thoracic surgery consult service were lung cancer, mediastinal masses such as thymomas, lymphomas, and then mediastinal hilar lymphadenopathy to diagnose or biopsy those. And so next, I'm going to go on to kind of a sampling of the guideline that we developed for each of those 3 general surgery consult criteria. And so the first here is lung or pleural biopsy. So we kind of wrote this policy so that all of these would be requested from the MICU or pulmonology service. And so they should have some demonstration of parenchymal disease of unknown origin, and all of the other diagnostic workup has been exhausted. And then we added that, something would be done with this biopsy. So it's the decision point to start high-dose steroids or immunosuppression or something like that. And then we asked that the consulting service document what the tests they want the specimen run for, whether it's permanent pathology or infectious workup. And then these patients would remain on the medicine or pulmonology service. And EGS or the emergency general surgery service would just follow and manage the chest tube until it's removed. And then here you see consulting EGS for pleural thickening enhancement. So something more thought of to be pleural in origin, where again, the same thing, the imaging shows it, the diagnostic workup has been exhausted. And, there's something that would be done with these results. And the next, spontaneous pneumothoraces. So we wanted to be consulted, the emergency general surgery to be consulted if the imaging demonstrated a spontaneous primary pneumothorax and it's recurrent. So the primary first occurrence pneumothoraces would be admitted to medicine for the workup and management thereof. And then EGS could be involved with chest tube management if necessary, but most of those first time occurrence patients, their chest tube is managed by pulmonology. Medicine should be consulted. Again, as I said, the primary, the first occurrence, and then also for secondary pneumothoraces, so complications of COPD being the most common. And again, as I mentioned, pulmonology is usually co-managing these patients with medicine in order for chest tube management. And then for pleural effusions and empyema, we decided to consult EGS and pulmonology. We wanted this to be more of a co-management strategy for these patients. If there's a perineumonia effusion or an empyema when initiating TPA or Dornase. So we wrote this to be involved in the decision-making, but not necessarily the gatekeeper of TPA and Dornase to enable its use and effective reevaluation to determine surgical need. The diagnosis of empyema is made based on a pleural pH of less than 7.2, a positive gram stain or culture of pleural fluid, or just gross purulence on chest tube placement. CT imaging should demonstrate a significantly loculated, persistent pleural effusion after a chest tube was placed. And then CT imaging can demonstrate, again, after DNase and TPA was administered, this persistent pleural effusion. And so, again, reiterating that EGS should be involved in all of these decisions of a repeat trial because wanting to limit the time to surgical intervention if deemed necessary. And then consulting medicine for pleural effusions where the differential is most likely an exacerbation of a medical comorbidity or in patients who are severely debilitated from their comorbidities and deemed not a surgical candidate. And then what you see here is an example of some of those resources that I developed for both my partners, the surgeons at Denver Health, as well as residents. This is published on the resident educational resource site that we have at Denver Health. But basically what you see is a standardized approach to the management of one of those EGS conditions. And so a standardized surgical placement or standardized surgical approach with things like positioning, lung isolation, port placement, and kind of general tips and tricks for the surgical procedure, following all the way through for post-op chest tube management and then even clinic follow-up. And so one of the next things I worked on was developing a formal thoracic tumor board at Denver Health. And so I wanted to establish a formal thoracic specific tumor board. Denver Health had one very general tumor board that met weekly and would be everything from urologic cancers, thoracic cancers to GI cancers. And so trying to pull out the thoracic cancers in order to have more specific expertise. And what I was able to do was expand on a pre-existing multidisciplinary conference that was held weekly between thoracic radiology, pulmonology, and thoracic surgery. And so what we were able to do was collaborate with medical oncology, thoracic radiology, and pulmonology to develop this. And what we did was we modeled it after the American College of Surgeons Commission on Cancer guidelines in order to be able to apply for accreditation down the road. And so what we did to establish this tumor board was first, we added the missing specialties from a physician group that are required. Here, this is a snippet from that ACS guideline. So we added medical oncology, pathology, and then radiation oncology. It's a weekly conference with, again, the assistance of the medical colleagues from pulmonology to discuss non-cancer and cancer cases to develop a multidisciplinary plan for all of our patients. And then one of the last clinical initiatives I want to talk about is slipped rib syndrome. So first I want to talk about what slipped rib syndrome is, but it's a often misdiagnosed and underdiagnosed cause of severe chest wall pain. And to understand what it is, we'll talk about anatomy. So the top ribs, ribs 1 through 7, are considered true ribs. They attach directly to the sternum via a singular costochondral cartilage. And then the lower ribs 8 through 10 are considered false, and they attach via a common cartilage channel. And then 11 and 12 have no sternal attachment. And slipped rib is when that common junction of that costochondral cartilage erodes and allows the rib to be more mobile. And it slips and pinches the intercostal nerve below that rib, and that's what causes the severe pain. It's most common in athletes such as rowers, tennis players, runners, and dancers, but we've seen it in many, many different patients, even post-trauma patients. And so one of the first things we did for slipped rib syndrome at Denver Health, once we started to see an influx of these patients, we worked on developing some diagnostic criteria, and we actually developed a CT protocol to see if CT protocols with specific reconstructions of the cartilage would be sensitive enough to discern this. We collaborated with our radiology colleagues to create a protocolized CT that added that 3D recon of the cartilage. And honestly, what we noted was that it's not that great at developing this or at viewing this, that oftentimes on patients with normal costochondral cartilage, you can still see, based on the limitations of the 3D reconstruction software, some gaps. So it's not the best. And this also was matched in the literature. And then what we also did was we worked with an ultrasonographer as well as the thoracic radiology group at Denver Health to develop a dynamic ultrasound, which is in the literature one of the more sensitive tests for diagnosing this. And we developed a protocol with radiology and the sonographers to pilot and detect slipped rib syndrome, and have had good success with this as well. And so what we do for this process is we evaluate the patient in clinic, and then we mark areas of concern or pain on these patients, or if we can recreate the slipping in clinic, then we also mark that area and send them over to ultrasound afterwards, and they can correlate. And what they do is they do a bunch of maneuvers to try and get these ribs to slip, crunching maneuvers, Valsalva, or pushing with the ultrasound probe. And then lastly, slipped rib syndrome treatment. So the kind of best established treatment for this is something called the Hansen procedure, after one of the surgeons who developed it. But it's a surgical stabilization that uses a permanent fiberglass suture to fixate or cerclage the rib and the costochondral cartilage anteriorly to the rib above it. And what this does is this stops the rib from moving and pinching that intercostal nerve, and oftentimes will alleviate the patient's symptoms. As I mentioned, at Denver Health, we've seen quite a big influx of this, and in the past 2 years, we've completed actually over 20 cases of this, and some of those have been bilateral patients as well, between the two of us surgeons at Denver Health that do it. And the interesting thing about slip rib syndrome is we've seen that it's a kind of self-growing patient population. And so really the referrals are gained through social media posts from patient satisfaction based on their outcomes and pain relief after surgery. And a lot of these patients are privately insured. So then moving on to educational initiatives. So something that has come of the thoracic clinical program at Denver Health has been resident experience. So as we've developed this program and increased our thoracic surgery volume, it's a site for thoracic surgery major case volumes for the residents. So things like endobronchial ultrasound, mediastinoscopy, VATS, whether it's mediastinal mass or biopsies, resection or biopsy, VATS lobectomies, decortication, hemothorax washout, VATS pleurodesis. And then always it's been a place for rib plating from a trauma standpoint. We have a standard approach to all of our rib plating patients. So if they're deemed candidates for rib plating, we do a bronchoscopy, rib plating, and then a VATS hemothorax washout just to reduce the risk of pleural complications from their rib fractures. And then, as I mentioned, surgical rib stabilization for slip rib syndrome. And then one of the other educational experiences that I've been able to do is with our rib plating courses at Denver Health. So these are rib plating courses for residents and fellows. As I've kind of worked through this and developed this curriculum, I've separated it out to be a junior-based and a senior-based or fellow, more complex advanced course. And what this does is the reps actually donate the materials and the surgical equipment. We use the same equipment and the same case equipment that we use at Denver Health for the surgeries. And so one, it increases resident familiarity with the sets and the rib plating. And then lets them get hands-on experience with plating these ribs. And we have two models, a more basic kind of exteriorized model, and then a more complex subscapular model that we use for the more advanced courses. And so here are some photos of residents with that. This is some of the more basic sets that we've used. And then these are the more advanced models where you can even have skin covering them. You can have the scapular tip that you have to retract to get subscapular screws and plates. And in addition to hands-on experience, what we do is we also have a brief didactics at the beginning of these rib plating courses where we talk about the data behind who you should plate, when you should plate, and the benefits of plating, rib plating in trauma. And then lastly, I want to touch on some research opportunities that's come of this program. So previous to me, there's been some participation in multiple multi-center trials regarding rib fixation for rib fractures and trauma. So some of the major trials there were CWIS TBI. CWIS is the Chest Wall Injury Society, so rib plating for patients with concomitant brain injury. Rib plating for non-flail rib fractures, and then also looking at quality of life after rib plating. And then one of the current studies that I am working on is assessing the quality of life after surgical stabilization for slipping rib syndrome. So as I mentioned, we have quite a good sized cohort with over 20 cases performed. And so we're doing a retrospective study assessing patient satisfaction and asking them to compare their pain before and after surgery. And what we're going to do is use the Orebo musculoskeletal pain questionnaire to assess that in these patients. And then furthermore, we have databases for rib plating for all all types of thoracic surgery cases that we perform. This is one, how we monitor and track our outcomes, but also it shows all the volume for all of the cases we performed. So there's a good potential to look at sensitivities and outcomes for the various thoracic surgery procedures. And then something we're in the kind of early talks about is working with the CWIS group again to look at artificial intelligence to recognize rib fractures and helping describe them in a standardized fashion. That's something that is an ongoing current discussion. So thank you again for the opportunity, and I want to open up to any questions.
Yeah, thank you. Questions and comments. Questions and comments, please. Dr. Mitchell, then Dr. McGee. we'll repeat the question.
Okay.
Hey, Dan, that was a really great talk. I just have a comment and a question. You know, when I was growing up in rural Weld County, it was not uncommon for the local GP or the family practice physician to do certain surgical procedures, appendectomy, delivering babies, things like that, simply because there was no one else to do it. But now fast forward 50 years, and while that sort of situation may still sometimes exist in certain areas of America, I would put it to you that elective thoracic oncology surgical care should be done by thoracic surgeons. And so, and particularly in an area like Denver. So thoracic surgeons are board certified, and for the residents, that means that they've undergone a rigorous training paradigm. You know, I rotated on neurosurgery as a resident, but I don't do craniotomies. And after their training, they take a written test and an oral test. And then if you pass all that, then you're deemed certified. And it's super important because it protects the public and provides optimal care for patients. So, and it is black and white in the literature that people who have surgery by thoracic surgeons, as opposed to general surgeons, do better. Their outcomes are better in study after study after study. So, but that's not the last word there. After you graduate and you have your certification, then you undergo continuous certification that everybody is familiar with. That does not exist within the ABS for thoracic surgery. There are no modules to allow for that. So people have to be thoracic surgeons to undergo continuous certification and to stay updated and assure the public that they're updated about the current training paradigms. So just as one example, treatment of early stage lung cancer is rapidly changing, almost on a month-by-month basis. And I would put it to you and anyone else that you need to be a practicing thoracic surgeon, just like in any other subspecialty, to really understand those new paradigms. So I have a question for you, and it kind of is at a Denver Health level. You know, we've seen the same sort of paradigm within the Kaiser system. And if the literature is very clear that the best care in these situations is given by thoracic surgeons, why does Denver Health not allow its patient population optimal care? And there are some things that they outsource, I know for a fact. Why don't they do that with thoracic surgery? Just help me understand. It can't be a question of money because they outsource other stuff. So tell me just from a programmatic level why that occurs.
Yeah, happy to. I think it goes back to some of the background stuff on my first slide, where, you know, we're often seeing patients who have nowhere else to go. They seek care through the emergency department and have very limited resources. And they also don't have the financial resources to go and seek care elsewhere. And I think to speak to a little bit of your comment, I think there is opportunities at Denver Health that we stay up with the literature and the newest guidelines. And that's where, you know, each of us surgeons having a niche and becoming an expert is we take the onus on ourselves, recognizing that our patients want to get care at Denver Health and to, you know, go through the entire process, whether it's surgery, oncology care, or chemo. And so I think it goes also to the financial straits of the institution with the largest increase in indigent care that Denver Health has had to have and has, you know, committed to still taking care of those patients. And that volume is increasing year over year. And so the aim of this is to provide cost-effective yet high quality and standard of care surgical care to all of our patients.
Yeah, and what I might add is I think it's incumbent upon all of us to figure this out. And, you know, my guess is that there's some patients there that have zero options. But there are probably some patients there that if we build the right infrastructure, would have more options, and we could increase the level of care for these patients. So I think all these points are well taken. This is a long conversation, and we should further pursue this. Dr. McGee.
Dr. VanDerPloeg, congratulations on your presentation. Again, to echo a little bit of what my partner said, you've taken, and I want the trainees to recognize, you've taken a non-standard approach to becoming a thoracic surgeon at an academic institution, of not doing a cardiothoracic surgery fellowship, board certification, et cetera. What professional barriers do you think that's raised, and how have you overcome them, or how do you plan to overcome them?
I mean, I think part of it is exactly what we're talking about here is why am I doing thoracic surgery when I'm not board certified in it? And I think to really understand that, you have to, again, understand Denver Health and the mantra of that institution. But I think the other barriers are what I alluded to for Dr. Mitchell, which is, then the onus is on me to follow the literature and to stay up to date with the guidelines. I don't have kind of this built-in recertification process that's going to put the most state-of-the-art, the most relevant articles in front of me on a regular basis. I have to seek those out. And I think that, plus the collaboration with other thoracic-specific expertise at Denver Health is how I work to do that and work to develop that.
I think, thank you for those questions and comments. Thank you for the presentation, and great job.
Thank you.
Everyone have a great week.